Good afternoon, class. I'm going to be demonstrating an assessment on a postpartum mom. You are going to be responsible for understanding and knowing this material when you come to the OB clinical. So this recording will be placed on D2L, so you can watch it as often as you would like, so that you can become proficient with the information. So, of course, you enter your patient's room by knocking on the door, introducing yourself, washing your hands. Good morning, or good afternoon. My name is Nancy Eaton. I'm going to be your nurse caring for you today.
Hello, how are you?
Okay, how have you been doing?
No, okay.
Yeah?
A little bit sore.
A little bit
but
sore?
I'm doing okay.
Okay, well, I'm going to be checking over that and seeing how you're doing. First off, I would like you to give me your full name and your birthday, please.
Okay, my name is Beverly Johansson, and my date of birth is May 12th of 1985.
Okay, and do you have any allergies to any medication or food?
Not that I'm aware of.
Not that you're aware of. Great, super. Okay. So when you come in the room, typically, just like we do for all of our patients, we're going to introduce ourselves, wash our hands, and two identifiers, name and date of birth. And of course, we want to check allergies. So I hear you've had a little baby girl this morning. How is she doing?
She's so beautiful. Her name is Hannah Rose, and I'm so excited to have her.
I know. Is this
scared, but excited.
It is different. Your life changes. Is this your first?
Yes, she is.
All right. Oh, well, you're in store for a lot of wonderful blessings, but lots of new things happening in your life over the next months and years. Yeah. So I'm going to start. When we do a postpartum assessment, we use the acronym BUBBLE-P. Okay. And the first B stands for breast. U stands for uterus. This next B is bladder. The next one is bowel. L is for lochia. E is for episiotomy. H is for Homan sign, and the last E stands for emotions. And we're going to go through each one of those, and I'll be stopping and starting and conversing with our patient today to help you understand maybe some of the responses that you may receive. Now, with any assessment, you still want to listen to heart and lungs. With our OB patients, these are typically healthy women, okay? And so we don't need to look in the eyes and the ears and the nose and the mouth, typically, okay? There may be some circumstances that we do, but we'll talk about those in a different recording. But we do want to ask her, of course, is she in any pain? So, Ms. Johansson, are you in any pain this morning?
Probably more sore than in pain.
Okay. Where is that soreness located?
Yeah, wherever I had the baby. I had a little bit of an episiotomy.
Okay. All right.
So it just kind of sore a little bit.
Sore. All right. On a scale of 0 to 10, 10 being the worst soreness or pain, how would you rate your pain?
It's probably a 2 or 3. Probably about a 2.
Okay. Is that tolerable to you?
Yes, it is.
Okay. All right. So, we want to know what where the pain is, what the pain scale or pain level is. Is it tolerable? Is she in need of any medication? And, of course, we want to know when her last pain medication was given so we know if we can medicate her if she needs it. All right. Ms. Johansson, I'm going to first start checking you over to make sure everything's going well for you. And we always start with the breast. And I want to know from you, are you having any pain, tenderness, soreness in your breast?
No, not right now. They feel a little swollen.
Okay, all right. That's not unusual. Have you had any leakage from your breast?
Just a little bit of clear.
A little bit of clear, okay. And that is what we call colostrum. It's kind of a clear yellow discharge, and that's the precursor to your breast milk. Now, are you planning to breastfeed?
Yes, I am.
Okay, super. That's wonderful, and we want to make sure you're feeding your little one at least every 2 to 3 hours, starting with 5 minutes on each side and increasing that as she is wanting to eat more, okay? Has the lactation consultant been in to visit with you yet?
Yes, the second time I breastfed her, she
Okay.
came in and it made it a lot better.
Super. They are wonderful, and they have a lot of resources, so they're a good resource for you to tap into even once you go home. So don't forget that. We'll make sure you have all those phone numbers. So just a little bit of fullness, feel like it's swelling, a little bit of leakage, any redness, lumps, bumps that you're feeling in your breast?
No.
Okay, great. So, when you're doing an exam, we're not going to just strip this gown off this patient, okay, and take her bra off. We're going to ask her these questions. If she says no to lumps, bumps, redness, significant discomfort or pain, we're going to leave it as is, okay? If she describes any of those, we need to get either myself, you need to get either me or your primary nurse that's caring for that patient, so we can look at that breast and make sure there's not any concerns for infection or mastitis, which is what we would be concerned about. The other thing is we want to make sure that Ms. Johansson is wearing a bra, and she is. If she wasn't, we would encourage her. Whether she's breastfeeding or bottle feeding, we want her to wear a bra. The bra, again, supports the breast. It prevents a lot of extra stimulation that doesn't need to occur, and then it just makes the moms feel a little better when they're supported. And then it just makes the moms feel a little better when they're supported better. Okay? All right. So now that we've talked about your breast, Ms. Johansson, we're going to check and see about how your uterus is and how it is in relation to your abdomen and how your bleeding's going. Okay? So when you're checking the uterus, it's going to be hopefully in the mid-abdominal area, okay? I'm going to show you on this mannequin, and then I'm going to show you on this torso here in just a minute. You always want to inspect the abdomen, and even though the U is a second assessment within the bubble T assessment, I typically, before I start mashing on mom's belly, I am going to listen to her bowel sounds, just like we teach you in a med-surg patient. So I want to know when her last bowel movement was, and when was it, Ms. Johansson?
It was yesterday evening before I came into the hospital.
Okay, super. And that is not unusual. Most women will have, if they have it before, they're not going to have it hopefully during labor or delivery, and they're definitely not going to have it right after. Very seldom have I ever seen that. But we do want to know when the last bowel movement was. All right. Well, one thing I want to encourage you, Ms. Johansson, is that you drink plenty of fluids, and as much as you can, get up, move around, eat fruits and vegetables, because that fiber is going to help stimulate your bowel, and you're going to be able to go to the restroom a lot easier. We don't want a hard stool because that's going to be much more painful and difficult for you. And so water, ambulation, and fruits and vegetables. And we're also probably going to be giving you a stool softener since you are taking some pain medication to keep that stool soft, okay? So you want to listen first, and then we're going to assess the fundus. The fundus, or the uterus, the fundus is the top of the uterus. And what we're checking for is how it is placed, or the placement within the abdomen. So here's my little pregnant or my non-pregnant torso, my postpartum torso. And you see right here this little bubble here, right? Okay. So when I'm assessing, and I want to put gloves on, okay, because I'm getting close to the area where her discharge, her lochia, is occurring, and I do not want to contaminate myself, okay? Hand washing is vital, okay? It's like #1 importance when we're caring for postpartum moms and babies. So I'm looking at her abdomen, I've inspected it, I've listened to her bowel sounds, and then when I'm wanting to see what how the uterus is in the abdomen, I'm going to put one hand along the symphysis pubis, along the pubic bone, okay, to give it added support. I'm going to take my other hand and I'm going to kind of walk down my fingers until I feel the top of the uterus, which is the fundus, okay? And the way we measure this is the relationship of the fundus in relation to the umbilicus, okay? At this point, this is 1 finger breadth, okay, or 1 finger below the umbilicus. You may see it charted as 1 finger below U standing for uterus, okay? So I'm first going to identify where it is located, okay? The other thing I'm going to look at is it midline or is it to the right or to the left, all right? If it's to the right or the left, many times this could mean that the bladder is full. And if you think about, the bladder is sitting here, the uterus is on top of the bladder. If it's full of urine, okay, it's almost like a water balloon, okay? And so that uterus is going to kind of tilt to one side or the other. And so if it's to the right or to the left, you want to take note of that. Once I locate where the fundus is, I'm going to massage it, okay? And I typically just start, very gently massaging, giving that lower suprapubic support and massaging and getting a little harder and harder with my massage. What I want to do is make sure this uterus is nice and firm. By massaging this uterus, it's stimulating a natural hormone in women's body called oxytocin. And that oxytocin is the same hormone that causes contractions during labor, but it also causes the uterine muscle to contract afterwards, so mom does not bleed any more than what's normal, okay? If the uterus was displaced to the right or to the left, at that point we would want to, if she's able to get her up to the bathroom, have her empty her bladder, then reassess where is that uterus, the fundus, in relation to the umbilicus. Is that uterus nice and firm, okay? And then also I'm going to be looking at her lochia, okay? And we're going to talk about that more here in just a minute. I have a pad to show you what you're looking for. But I'm going to be looking, is she gushing blood, or is it a little trickle, or is it just a little bit on her pad? Okay, so I do that pretty much all at the same time. Okay, so she's nice and firm. She's 1 finger width below. Typically right after delivery, within just a couple of hours, it's either at the umbilicus or above. Usually by day 2 or 3, it should be 1 to 2 fingers below, and it's going to continue to get smaller and smaller until about day 10 to 12. It's not going to be able to be palpable at all within the abdomen. Okay, it goes back down about half centimeter to 1 centimeter a day. All right, I'm going to take my gloves off if I'm not assessing her abdomen or her lochia. Okay. All right. Ms. Johansson, how is your bladder? Are you urinating okay?
Yes, I am.
Okay.
I do have a little bit of burning whenever I start to...
Okay. That's not unusual because you said you had an episiotomy, correct?
Yes, ma'am.
Okay. And so as that urine unfortunately streams over that episiotomy, it may have some burning, and then again, those tissues down there are swollen, they've been stretched, and they're kind of inflamed. So that is to be expected. But what we want, again, we want you to drink lots of water to prevent urinary stasis, and we want you to be able to empty your bladder and clear that out really well. And after you go to the restroom each time, we do, whether it's a urination or a bowel movement, we want you to clean your perineum with warm water. And what you do, you just take this bottle, fill it up with warm water, or half a bottle, it doesn't matter, whatever you think it's going to take. After you urinate or after a bowel movement, you want to spray that warm water over your perineum real well, take the tissue and pat dry, and then let it air dry before you put a clean pad and your panties back on. Does that make sense?
Yes, ma'am, it does.
Okay, super. All right. So when I was talking about checking that fundus and giving that suprapubic pressure and massaging the uterus, I'm also going to be checking the lochia. And hopefully you can see this pad real well. And, this looks like a lot of blood, but it really isn't because it's not saturated all the way through the pad. I would call this probably a moderate amount of lochia. And the lochia is described by lochia rubra. That is the normal color of lochia the first 3 to 4 days after delivery. Now, she is passing some small clots. Again, Ms. Johansson, that's not unusual, but if they're more than like a quarter size, or there are multiple clots coming out when you're walking around or just laying here in bed, we need to know about it, okay?
Okay, you can pull the blanket down a little bit more if you need to.
Okay, well, thank you. I appreciate that. Okay. So hopefully y'all can see that, and we want them to kind of pull their legs apart so we can see very clearly. And so when we're massaging that fundus, okay, we want to look to see if there's a gush or a trickle of that blood coming out, or any clots that are being passed. Now, I see this, and I am not going to leave this here, okay? Even if she, I may ask her the last time she voided, the last time she changed her pad. If this was 10 minutes ago, I'd be a little bit more concerned, okay? If it was 3 hours ago, I wouldn't be concerned. But one thing I do want to encourage you, Ms. Johansson, is that you do change your pad every hour or so, every couple of hours, every time you get up to the restroom, so that you have as clean a pad as possible. We don't want you to get an infection since you do have an episiotomy, okay?
Okay, that's fine.
All right.
You need to pull the blanket down a little further, that's fine.
Okay, thank you. Okay. All right, well, let's go ahead and get this pad changed. Her fundus is nice and firm. And I just usually just kind of roll this up, okay, and throw this in the trash. And then I get a clean pad. We put a nice clean pad on her, okay? Again, if she has a lot of blood on her skin, we want to wipe her up because we want to minimize the risk of any type of postpartum infection. The other thing, Ms. Johansson, you mentioned earlier that you were having some discomfort or soreness down here.
Yes.
Well, your doctor has ordered an ice pack that we can apply to your perineal area for up to about 24 to 36 hours. And so I'm going to do that. And students, this is a makeshift ice pack. What we do, we take a baby's diaper and we separate the cloth from the stuffing inside. And we put ice in like a glove, okay? And we put that down in there and then we fold it. And it's a homemade ice pack. But what's nice about it, it's absorbent, it's cold. When the ice melts, it stays inside and it doesn't run all over the bed. So I'm going to put this right next to your perineum. If it gets uncomfortable, you can take it off, but leave it on for at least 20 minutes if you can tolerate it, so that you can start feeling a little better. And that's going to help with the discomfort. It's going to help with the swelling as she continues to heal. All right, so we have covered breast, we've covered the uterus, we've covered bladder and bowel, lochia, and the episiotomy. Now, I didn't turn her over. If she described to me that she was really uncomfortable, or I was noticing some bleeding, but the fundus was nice and firm, bleeding that just kept coming and more than I would expect, I would probably want to roll her over to look at that episiotomy to see if it's still approximated well. Also, if she complained of hemorrhoids. Hemorrhoids are not uncommon with pregnancy and especially after vaginal delivery. We may need to take a good look at that and make sure they're not thrombosed or that we need to call the doctor and see if we can get some other medication. And that's another reason we would want to keep her stools nice and soft. So if she does have hemorrhoids, it's not too painful for her to go, because if it is, she's going to keep from going. She's going to hold it in and be afraid to have a bowel movement. All right, so the next thing we're going to do is talk about Homan sign. It is not recommended, best practice says now that it is not recommended to do what we call a Homan sign. And what that is where we would take the patient's leg, have them hold it out straight, pull back their foot, and let it go. And if they had pain in their calf, okay, and we would do it on both legs, that might indicate a deep vein thrombosis. Pregnant women and postpartum women are at high risk to develop a DVT. instead of doing that, and the reason for it, there's some concern, there's some evidence that you might dislodge a clot, and where does that clot go? Well, it can go to the lungs or the heart, and we don't want that to happen. So now what we do is we look at the legs. We want to look at both of them just like you do on any patient that you take care of. You look for swelling, you look for edema, you look for any redness or red streaks up and down the leg, and you ask your patient, is there any pain in your legs when you're walking or even when laying here, okay? And you need to look at that and evaluate and assess that, okay? And so, that's the next thing you would want to do. We don't want to be doing the Homan sum, but we still are required and need to evaluate that. The last thing is what we call E. It stands for emotion. Women that have had babies, have all sorts of emotions. They're happy, they're sad, they're upset, they're who knows, okay? And so we're going to check. Ms. Johansson, how are you feeling overall? You mentioned you were happy earlier, but...
Yes, I'm very happy to have Annie here, but I can watch TV and I'll cry at one of those commercials very easily.
Yeah.
And when I look at her, I'll just cry. She's so beautiful.
Yeah, I know. It's a very emotional time, and those are real normal feelings, okay? To be happy, not to be so much sad, but just have those emotions, and you can't really explain them. There are 3 phases that most women, or all of us, go through after having a baby. The first one is taking in. Taking in is you're probably really excited when we come in here and show you new things about your baby, aren't you?
Yes,
yeah.
Very excited.
Yeah. They like us to show how to bathe, how to hold, how to feed. And that's what that means, taking in, just bringing it all in and holding, just taking it in and enjoying this time. But then there are some of those emotions that kind of come out sometimes because it's like, oh, wait a minute, tomorrow I'll be going home and I'll be doing this myself, okay? So taking in, taking hold is where, okay, I can do this. I can be a mom, and you will, okay? You are already. In a few days, few weeks, few months, you're going to start feeling more like yourself again. You're going to feel like I can do this, and you don't want anybody else to do it because you want to prove to yourself that you can be that wonderful mom that you want it to be, and you are. Letting go is usually a little bit later, probably after a couple of weeks. And guess what? You're ready to go on a date with your husband, or you're ready to get out and go with your friends to a movie, or maybe walk the park. And that's that letting go of when, okay, yes, I'll let Aunt Alice come over and take care of little Hannah, just so I can, it's okay. I'll let Daddy take care of her. I'll let Aunt Alice to take care of her, Grandma or whoever, just so I can maybe have a little bit of me time. And there's nothing wrong with that. You're starting to trust others to care for your little one, that you're not the only one that can do it, and you start realizing that you can't be the only one because there's a lot to do. So that is your bubble He assessment. Of course, before we leave, we want to make sure the call light is within reach, asking your patient if there's anything else that you can do for her. Is there anything else, Ms. Johansson, that I can get you today?
No, I think I'm okay.
Okay. Your pain's controlled, your bleeding is under control. Now remember about that ice pack. If you need another one, let us know, but we'll want to leave it off like 30 minutes in between, okay? But, really, once it gets, a little bloody or it starts melting, you just throw it in the trash. That's all you have to do, okay?
Okay.
All right. So call us if you need anything, and I'll come by and check on you here in a little while.
Okay, thank you.
Thank you.